Good morning, good afternoon, and good evening, everyone. Uh, thank you for joining us today on our important session in leveraging evidence to inform maternal and child health improvement or maternal health improvement strategies or interventions. So this is a webinar, one of our webinar sessions that we have been doing as a PhD system strengthening webinar series for the last 4 years. This has been a good experience to interact with you and share experiences from all over the world. Thank you again for being with us today. So today we'll be collaborating with One Health Global Alliance on these important sessions, and we have an important and a senior experts lined up here for this session. We hope we will have a great and interactive and engaging sessions with you all. As we collaborate with One Health Global Alliance, so I would like to hand to Dr. Takom, Chief Operation Officer from One Health Global Alliance, to say a few words and make an opening for this session. Over to you, Dr. Takom. Thank you.
Thank you so much for those remarks, Rasid, and for the introduction as well. We really sincerely appreciate, want to extend my appreciation to the team at the International Institute of Primary Healthcare Ethiopia, really for their leadership in advancing primary healthcare in the country and beyond. On behalf of the One Health Global Alliance, it's truly a pleasure to join all of you. I want to thank the speakers as well as the moderator for the session. And as I mentioned, we're really delighted to partner with IPHC on this important webinar, and we see this collaboration as a meaningful step towards strengthening shared learning and collective action across all of our networks. As you heard, the focus of today's discussion, leveraging evidence to inform maternal health interventions, is really critical and timely. And this, in Ethiopia and the region and globally as well, this maternal and child health intervention is really foundational to strong health systems, we believe. And while there have been progresses, as you all would know, there's still a great deal of work to ensure that women and children everywhere have access to the care that they need. I'm looking forward to hearing perspectives and experiences that will be shared today from our experts about what's working, what are the challenges, and where there are opportunities to do better. We're thrilled to be partnering with IPHC on this, and we really look forward to building on this collaboration moving forward on these types of activities and beyond. With that, it is my pleasure to introduce our moderator, Dr. Solomon Bezawergo, also a colleague of mine. Dr. Solomon is a physician and public health expert with over 24 years of experience across academia, health programs, and policy. His work focuses on health systems strengthening, particularly in human resources and maternal and child health. He currently serves as a strategic regional director for the Ohio State Global One Health Program. Dr. Solomon, over to you.
Thank you so much, Dr. Takom, for that introduction. And it's an honor and a privilege to be moderating this very important session to this afternoon, leveraging evidence to strengthen maternal health intervention. Just to give a brief context of this webinar, over 90% of maternal days actually occur in low middle income countries. And fortunately, majority of these are preventable through cost-effective and high impact and evidence-based interventions. Despite global commitments on sustainable development 3.1, which is reducing maternal deaths, less than 70 per 100,000, progress has stalled the past few years, especially because of many reasons. But to mention few of them could be due to inconsistent implementation, weak health system, and also inequitable access for quality maternal health. So I believe evidence plays a critical role in terms of for helping countries get back on track in terms of meeting SDG 3.1, which is improving maternal health or reducing maternal mortality to less than 70 per 100,000. So today we have three distinguished panelists, and each will give us they will share their insights in terms of the role of evidences in improving maternal health. Each of the speakers are going to have 15 minutes for the presentation, and the last 30 minutes is going to be for question and answer. So I encourage participants, whatever question that you have, you can put it on the chat or in a Q&A so that the speakers would address it at the end of the presentation. So having said that, I'd like to invite the first speaker, who is Dr. Laura Shalaha. Let me give you her brief bio. Dr. Laura is a professor and director of research in the Department of Family Medicine at UCSF Health Morsani College of Medicine. She is a methodologist and a statistician. She collaborates on federally funded research and mentors faculty and students in research design and analysis. Her NIH funded work focuses on health disparities, cancer screening, and intervention research with racial minority and undeserved population. She has served as a methodologist on the NIH P60 Center grant, an evaluator for NIH T32 programs, and was a member of NIH expert panel on operationalizing culture for health disparities research. And there is so much. It's wonderful to have you here, Dr. Laura. The podium is yours. You have 15 minutes to do your presentation. Over to you, Laura.
Thank you very much, Dr. Bisa. Let me share, see if I can do this correctly. Okay, so there we go. I am here a little, what is the word? I am standing among giants, is what I would say. I'm actually a researcher who is concerned with the methodology, statistics, qualitative, etc. And so my approach will be slightly different in terms of not the what, but the how. The key is for all of us to move from evidence which has been gathered already and to move into implementation at scale. We already have the evidence we need. We know about hemorrhage, we know about hypertensive disorders, we know about what happens or doesn't happen in terms of postpartum care. The key is the gap between that evidence and the actual implementation. We have delays in recognition, we have sometimes fragmented follow-up and inconsistent adherence. This is a key component in order for us to actually move forward. The famous statement from studies maybe 20 years ago, in fact, was that there are 17 years between the establishment of the efficacy and actual implementation in everyday life. This is where we need to move. And I suggest there's another place to go as well. Our need to use an equity lens in order to do this. That is, we need to have access and workforce gaps that we need to attend to, respectful care that we need to attend to, and community support. This is the path that what I am hoping for. Maternal mortality is driven by gaps in implementation, not by a lack of evidence necessarily. One of the more difficult things for people to do is to embed equity into the evidence pathway. How did you get there? Not just the outcomes. There's been a major shift in current maternal health science. The old model would say, okay, give me the average treatment effect and evaluate that. Whereas now, the emerging model is one of evaluating differential implementation here, here, and here, and that particular impact. It's sometimes challenged. If all of us who have been trained in the classical way would say, oh no, I only need to focus on what's happening here in this particular place, and all of the rest of this somehow is a challenge to our quote unquote objectivity. Well, I want to say that welcome to the postmodern age. There's no such thing as objectivity in this regard. And in fact, what we need to do is to move beyond that to how is it working and with an equity point of view. Most maternal health studies answer, does this work under controlled conditions? But policymakers and health systems and people who control the purse strings need to know, will this work here with our workforce, with constraints, and with our patients? I don't know. It's just so I'm a Catholic. I seem to do everything in a Trinity. But anyway, the key is to have our interventions, whether they are bundles, remote monitoring, community care, and then secondly, most importantly, look at the mechanisms, right? Is it early detection? Is it standardization? Is it engagement that enables us to actually get to the outcomes of morbidity and mortality, as well as equity in and of itself? Many times in reviewing proposals, I find that the first question is about efficacy, and the second question is about potential mediators and moderators, and then the third one is, oh, and what is that mechanism if they get there? And of course, it's powered for number one and maybe number two. So here I am doing an advertisement for mechanisms and measuring it, right? We need to move forward designing for real world context. We need to study these mechanisms, how, why, where. It's going to be different, guaranteed. We have different people in different places with different contexts that we need to attend to. We need to measure time to care and adherence. And we need to use a hybrid effectiveness implementation design so that we can always attend to or speak to the effectiveness. But the key is we're moving ahead. This is how we implement this here and now. We know X will work. The key is how to do it. You can tell I'm a methodologist because I like to hammer on this a little bit, but you want to make these mechanisms explicit. We have a key opportunity here where, yes, we evaluate our interventions, but the mechanisms are not measured, right? We have a community health worker program. We know that this works, but yet we're not saying how does it work? We know it. Do we measure the trust, care navigation, or a timely escalation of things? If you cannot measure the mechanism, you cannot scale the intervention. This is especially important in LMIC and US disparity context. Context drives the effect size far more than the intervention itself. This brings us to both opportunities and challenges when we're doing this. The key is to embed the evidence into routine care, that what we do, how we do it. You need to design for equity. If you don't, you will not have it. And partner with the communities. Our opportunities are clear. Safety bundles, we can do telehealth here, we can have a community workforce and respectful care to do these pieces. The challenges, more often than not, are workforce gaps, fragmented systems, sometimes a limited infrastructure to work with, and that risk of inequity. Interventions fail less because they are ineffective and more because systems are unprepared to deliver them. Now, here I am sitting amongst the giants who can tell you this. In fact, the lessons from African settings and their global application has happened there. This is where we find the innovations that I'm talking about, such as task shifting, having community-linked care models, the continuity of care approaches, and a pragmatic use of limited resources. The key is to know which is fitting where. And of course, our global application. The key is to remember, do you want to design for scalability from the outset? You want to integrate always community and facility care. You want to adapt interventions to what the context is and prioritize equity in implementation. Here is I can say that one of the things I can be embarrassed about. One of the studies that we have done is in Ethiopia, and we got a brand new machine so that we could do a vinegar splash and to see potential lesions or things in the vagina, and we could freeze them. Boom. Take them out. Everything is great. So we're very happy. We know this is effective. We go and we demonstrate how to do this, et cetera, et cetera, et cetera. But we missed one important thing. This uses a gas to freeze things, etc. And what we didn't think about is the availability of medical grade gas to do this. And so because there was no available medical grade gas, they used the gas from the local brewery. Smart thinking, I suppose, to hit it. Unfortunately, the machine, which we got from Germany, did not like this very much. And at some point, we had a case where we have a woman who is here, and we have done this, but the wand is not unfreezing. What's the problem? And we call and give a hard time to the people in Germany, but in fact, no. There's a piece of the local context that we missed and then needed to go back and to fix. There's always something. But as I say, most effective innovations that we have, as I've mentioned a couple of times, have emerged from the African settings, and those should inform implementation strategies everywhere. One of the studies that we're in right now is for women to do their own self-testing, or at least gathering of the sample, in primary care clinics here in Tampa. And this goes back to almost 20 years ago. We were in Mumbai and we were testing this, and we took a clinician took a sample, and each particular patient or participant also took her own sample. And we found that the samples were just as good with the women doing them themselves, and slightly better in some cases. So this is what we're doing to see if this can be implemented in primary care here. We have a hybrid 3 type design. And if you're doing implementation, you'll know, well, how is this one different from the other? Hybrid 3 is an approach that primarily tests the effectiveness of the strategy, that is, how to deliver a practice, while simultaneously gathering that secondary data on clinical outcomes. It focuses on adoption, fidelity, and sustainability of evidence-based interventions in real-world settings. We have 4 clinics who are doing this. We are hoping for a final sample of 120 women who are non-adherent or who have never been screened for HPV. Our aims look familiar, and hopefully they actually address the things that I'm demanding that we do. That is to evaluate the implementation self-test intervention for engagement, for feasibility and acceptability. Secondly, to look at the primary efficacy, but remember, secondary, we already know that this is efficacious. We are just adding this in this piece to guarantee. And third, to conduct and analyze qualitative interviews with participants, 20 females who are eligible for HPV testing, and 20 key stakeholders, the physician, the nurse, the physician's assistant, the psychologist, etc., to talk about what are the challenges, what are the needs, and the perceptions related to doing this, what major miss was there, or what minor miss, and then what should we do? It's 2 parts. We're concerned with the navigators, and we're concerned with the self-test. Standards, again, in terms of what we're going to do, but notice the question is less about our outcome and more about how you get there, right? Feasibility, reach, participant acceptability and satisfaction, the completion of the self-test, the results of the test, but implementation fidelity, what adaptations are needed, the number and the length of intervention visits and dropouts, etc. Provider satisfaction, an important piece of what's going on, knowledge and barriers, the implementation climate in and of itself, and sustainability. To date, we have 40 participants. The facilitators noted that the physicians are champions, which is good, and navigators have access to the electronic medical record. And there are barriers. Women lack the time, and they want to leave. We are unable to call them ahead of time to inform about the study because of IRB, so that needs to be done. Sometimes there are language barriers. Sometimes, of course, there are no-show patients, and so we need to continue to work with this. In the classic mode, of course, you wouldn't change a thing and you would go forward, but this is not what we're talking about. We're talking about implementation, putting things into place. I'd like to suggest that this is a good model to follow, where we have evidence-based interventions, looking at those mechanisms, how in fact those things actually make the difference in order to get to our desired goal in terms of lower morbidity, mortality, and greater equity. Implementation quality determines whether evidence translates into equitable maternal health outcomes. The last three I will give you is that maternal health impact is maximized not by generating more evidence, but by aligning three elements: the mechanism-informed interventions, the context-responsive implementation strategies, and continuous learning systems that adapt evidence in real time. I feel like this has been a public service announcement. Thank you.
Thank you so much, Laura.
Thank you.
For that great presentation. I think you've touched upon a lot of important things that I think participants must have taken quite a lot, and they also for sure would have a lot of questions for you. And I'm so happy participants are from all over the world. I'm seeing people from Jakarta here, Liberia, Sudan, Kenya. We're pleased to have you here, and then more is gonna come. I think Laura has repeatedly emphasized on the importance of mechanism, studying the mechanism when it comes to evidence. Evidence by themselves are not enough. We're also able to understand what the mechanism is like, and we should also be able to study it. So thank you for highlighting that. There is going to be a Q&A session at last. So let me invite our second speaker on this panel. It is Dr. Hannah Brown Amoka. She is a public health physician and a clinical epidemiologist with 2 decades of expertise in clinical research, practice, academia. She currently holds a position of visiting assistant professor at Global Health at the University of Medical Center, Utrecht, and serves as a research fellow at Noguchi Memorial Institute of Medical Research, where her focus in maternal health and preeclampsia outcomes in low and middle income countries. Her portfolio includes oversight of clinical trials and development of digital innovations to enhance maternal and child health. Dr. Amoka area of interest encompass maternal and child health, health system strengthening, and cardiovascular research among vulnerable groups. She's committed to advancing health equity through rigorous research and cross-sector collaboration. Her professional contributions include serving as a core team member of the Lancet Commission on Synergies and as a junior member of Independent Advisory Committee for the Global Burden of Disease. Dr. Hannah, it's wonderful to have you here. Maybe would you share the Ghanaian experience or talk about the challenges and opportunities in implementing in the implementation of maternal health intervention? Over to you, 15 minutes.
Thank you very much for the kind intro. So yes, my name is Hannah, and I would quickly zoom into the topic of discussing the challenges and opportunities in moving from evidence to implementation and share some regional and Ghana experiences with you. I mean, you've already heard from Laura. We already know a lot. The evidence base for maternal health is very strong. We know that the mothers survive when they get access to skilled care during pregnancy and childbirth, when complications are managed early, when referral systems function, and when women are treated with dignity. So the issue is not a shortage of proven intervention. The issue is whether the health systems we have in place deliver these interventions reliably to every woman who needs it. I'll give you the example of Ghana. We have so many interventions, and this is actually just a summary of the many interventions we have. Broadly, there are several sub-interventions under each of these categories that I mentioned here, ranging from the free maternal care via our National Health Insurance Scheme, family planning services. We have established referral and ambulance systems. We have health tools for providers. We do have ongoing maternal death reviews to improve the quality of care through learning and respectful maternity care, amongst many, many, many other interventions. Yet, this is our reality. This is the Ghanaian reality. This is the African reality. We are still far off from where we should be when it comes to the SDG goals. In Ghana, we have 234 women dying per 100,000 live births due to pregnancy-related causes. We have made substantial progress, but progress seems to have stagnated over the years. And this Ghanaian story is also an African story. And we need to be able to move ourselves from where we are now and improve maternal health outcomes. There are a number of challenges in maternal health intervention implementation, and I try to use this slide to summarize some of them. And I think we've heard bits and pieces of it from Laura's presentation, for instance. The first challenge is the do-no gap. Again, we conduct many successful pilots and quickly learn that in real world, it doesn't happen like that. Our success stories are quite different because we work in very closely controlled environments or monitor the environments under which we conduct our pilots. Once we start to scale up, the health system gaps become exposed. And there is the never-ending problem of staffing, logistics supplies, and health system financing. Our referral systems tend to be weak despite our many systems that we have put in place to deal with this. And we face delays in attending to emergencies. We don't optimally use our data that we routinely collect. And there are so many fragmented services and research efforts. These speak to health system bottlenecks, as I have summarized here. And lastly, a third challenge I try to propose here has to do with quality and respectful care, where we see inadequate coverage and distrust of women and their families due to poor experiences that they get once they enter the health system. Now, having said this, I would like to elaborate a little bit more by sharing a few case studies on work that I have done to exemplify the challenges and opportunities to move from evidence to implementation. And I'd like to start with the Preeclampsia Care app. This is an app that was developed by the Severe Preeclampsia Adverse Outcome Triage Studies, that's a SPOT studies, whose ultimate aim is to improve the care of women with preeclampsia in Ghana and, of course, beyond. Now, this app is currently available in the Play Store. You can actually go to the Play Store now and check it out. You should be able to find it. It's available in the Play Store, and it consists of an algorithm that guides risk communication and shared decision-making in the preeclampsia care scenario. And these are a few screenshots about the contents of the slide that I'm trying to share with you. There are reminders for healthcare workers. There is a patient and journey. So this screenshot, for instance, the second from the left, exemplifies some of the guiding conversation that needs to take place at admission regarding maternal care. There are several communication topics that sit in this app. And as I mentioned, the goal is to improve risk communication and share decision making. Now, taking this case as an example, why was this app created? Again, the evidence is clear. It's clear that the digital tools help bridge access and knowledge gaps, thereby improving equity and outcomes in healthcare. How to move this evidence into implementation in the preeclampsia scenario led to the co-creation of this app that we hope will respond to these known gaps in risk communication and shared decision making. As a background, we do know that, yes, 25% of preeclampsia cases occur removed from term. And this is about 26 to 34 weeks, which is quite early. And these preeclampsia cases are responsible for many adverse maternal and perinatal outcomes. Yet, treatment delays also often occur due to poor risk communication, thus affecting provision of care and experience of care, and consequently the health outcomes. So the SPOT study aimed to co-create this tool to support clinical care provision for these women who have hypertensive disorders of pregnancy, particularly preeclampsia, removed from term. based on, first of all, their predicted or absolute risk of adverse outcomes, and then not just end at calculating a certain risk or knowing a certain risk, but actually moving on to engage in a conversation where you talk or engage in risk communication and share decision making where possible. What I like about what we tried to do was not to end at just creating a tool, but going forward to evaluate the effects of this tool. And for our methodology, we use co-creation as a process to co-create this tool and subsequently implement it in a clinical setting using pre-post-study design. And just like Laura said, not just look at the quantitative bit, look at the qualitative bits. What are the softer issues? What are the mechanisms? Not from just the views of the healthcare workers, but also the recipients of care, the patients themselves, their family members, in order for us to be able to understand how well this tool works. At the moment, we are still in the implementation phase, but already from our pre-study work, we can see that we communicate poorest at the implementation at the postpartum phase of care when it comes to preeclampsia. And this is interesting because it becomes relevant to see how this tool improves these phases of care for women once they do deliver. Again, research is fraught with challenges, and we've had many challenges. Getting our app into the App Store has been a really, really big hurdle for us. As researchers working with online developers, we were oblivious of the hurdles we needed to jump to get the app into the App Store. There's a lot of documentation that Apple requires, and this has not been completed to date, nearly 1 year on. And this has severely affected our pilots. And thus affected the reach of healthcare workers. Because in some cases, we realized that as many as 70% of clinical teams were actually Apple users. And so one needs to quickly think about other approaches to be able to make sure that other users are also able to have access to this tool that will aid in risk communication. Again, another challenge that we have had is how do we sustain the use of the app? How do we get health workers to be motivated to keep using the apps? And one of the things that we tried to do as a project was to engage SOGOG. So SOGOG is the Society of Obstetricians and Gynecologists of Ghana. Engage them to publish the app. They are obstetricians. They have an interest in preeclampsia. Can they sustain its use beyond the lifeline of the project? And we thought so. And so we are working very closely with them to be able to make sure that health worker motivation to use the app continues beyond the lifeline of our projects. The second case study that I would like to share to you is still related to the spot study, but it has to do with genetic research in Ghana. Answering the question, is the APOL1 gene a risk factor for preeclampsia? This info diagram here is basically telling you about the distribution of the gene in our sub-region. Again, what does the evidence tell us? The evidence said from previous studies outside of the sub-Saharan context that fetal and non-maternal APOL1 genotype was reportedly associated with the risk of preeclampsia. At the time, there were no cohorts of African-American women with preeclampsia that existed at the time of the findings of this particular study. And so, again, trying to bring the evidence into implementation, we have the highest burden of preeclampsia in sub-Saharan Africa. How are we going to leverage on this to develop intervention that will help us to risk, if it were true that indeed the APOL1 gene was reportedly associated with this risk? So we decided to organize this case control study to determine whether fetal or maternal APOL1 genotype predicted preeclampsia. Again, this is an interesting study that required us to do extensive biospecimen collection, including placental, cord blood, saliva swabs, so on and so forth. At the moment, the results are being finalized, and I'm sure a publication will come out soon, but it's already showing us that we could not validate or replicate, I should say, this genetic study that was done outside of our region. We could not replicate that in the Ghanaian cohort that we worked with for the spot study. And we had a lot of challenges in setting up this study. The infrastructure required in terms of freeze and storage, transport, capacity building of personnel to understand what it means to take on such a huge road to collect all these specimens, the culture of the people, what were the ideas and ideology about taking placental samples and cord blood, so on and so forth. These are challenges that need to be thought through. And again, engagement required in order for you to be able to move this evidence into implementation, to ask questions that fit your context and find answers that indeed fit your context. And that was the second case study I wanted to share with you. There is a last or third case study, I should say, which regards the PRESSURE study. PRESSURE stands for Preventing Severe Hypertensive Adverse Events in Pregnancy and Childbirth. And it's a biobanking effort in Tanzania that is using the PRESSURE cohorts. Once again, what is the evidence? We know that biobanks are crucial in investigating biological mechanisms, including pregnancy complications, to improve maternal and fetal outcomes. We know that if you go to many high-income countries, because they've developed biobanks over many years, they are able to go back and answer so many different research questions that become relevant for their population as time goes on. However, we have limitations in terms of availability of biobanks for maternal health in our sub-region. And that's why I thought it was interesting to share the efforts of the PRESSURE study that's trying to establish a repository of biological samples with a supporting limb systems that should make it very easy for one to be able to pull samples and do analysis. And this is nested in the PRESSURE study. Again, a lot of work going in there, and extensive infrastructure had to be developed to store and the samples, transport the samples, and build capacities. Challenges, again, very similar to Ghanaian challenges in terms of personal capacity, resources, and a culture. Again, contexts are different. In the Ghanaian spot study, we didn't have, for instance, this concern that there is a research team and the research team has taken over the work of the healthcare workers. But we realized that in the Tanzanian setting, there was a certain expectation that, if there are RAs who can check blood pressures for us, why not just let them check it? And then when they check it, we write it down. Again, these are little nuances here and there that you need to work out. They are challenges, but they are challenges that can be leveraged for you to see opportunities and build on them. So here I try to summarize some opportunities to move evidence into implementation. And I think the key thing I want to say that every challenge presents an opportunity to improve maternal health. We should not stop at creating interventions. We need to shift to implementation research. How does it work in the real world setting? What is it going to cost us? We have all these fancy things that we develop or are developed from other places, and we carry them wholesale into our context. Laura's example is very clear. That link was missing as to the type of gas to be used. How can you also adapt locally? And how can you sustain at scale? These are questions we need to answer for ourselves to improve maternal health outcomes. And of course, we also need to use existing platforms. Ghana, like many countries in sub-Saharan Africa, have a lot of systems, routine data systems, maternal death reviews, quality strategies are available, the community-based health planning services. All these are available for use, and we should leverage on them as opportunities to address these maternal health problems. The last opportunity I'd like to share with you is about building a responsive maternal health system. And to do this, we need to embed researchers in systems. We need to create that ecosystem that allows researchers to find each other, find implementers of healthcare services to answer questions that improve maternal health. We need to prioritize implementation outcomes. They may not necessarily have to be hard-end outcomes. Process outcomes are very, very important, as we have heard today. We need to commit to funding scale-ups and not just ending at the pilots. We need governments to commit. We need communities to commit. We need to engage in cross-country learning and to also center women's voices. And what do I mean by centering women's voices? The next is a slide I borrowed from Koilabi. This, she says, is her inspiration. I'm a 4-time survivor of preeclampsia. 3 of my 4 babies were born between 27 and 30 weeks. 2 died after a few days. 1 died in my womb. I'm on a quest to find out what I did wrong. Koiwa turned her tragedy into a big story, a story to support women who have also survived preeclampsia and to engage in preeclampsia advocacy. What I'd like to say is that, again, these women may not necessarily speak our language, but they hold the answers. They know the what, the when, the how, the why, the where, but will not say it the way we say it. Let's augment their voices. Let's engage in transdisciplinary research. Let's hear them so that we can improve maternal health outcomes as we move from evidence into implementation. Thank you very much for your attention. This is who I am and how to reach out to me. And I will stop here. Thank you very much. Over.
Thank you. Thank you so much, Dr. Hannah. That was brilliant. We seem to learn quite a lot, and I believe that the participants must have taken a lot of insights from your talk as well. I'm not going to repeat everything that you said, but I would like to highlight 3 important things that you've mentioned, especially when it comes to the challenge. I think all African or developing countries must also share all those challenges that you've mentioned, including the do-no gap, the health system bottlenecks, and of course, the quality. It's also wonderful that you shared some digital solutions for some important maternal health issues like preeclampsia. When it comes to the opportunity, I think it's also very, very important that that you emphasize, we need to also focus on the implementation research. Evidence generation is not only understanding what works, but it's also how it works and its practicality, the context, and the cost and the sustainability. That are the key takeaways from my side, and participants must have quite a lot. So let's move to the third speaker, a good colleague, a friend. The third speaker is Professor Merkuze Walde. Just to introduce him briefly, Professor Merkuze is a health policy and management specialist with more than 20 years of experience as a researcher, educator, and policy advisor in public health and health policy and system management. He has led several health policy and system research projects focusing on community health systems, maternal and child health service quality and utilization, health equity, and quality of health services. He's well published, having more than 95 peer-reviewed publications. He is a senior advisor for health policy and systems at the Ministry of Health, Ethiopia. Professor Merkuze is also Deputy Director for the Evidence to Policy work stream of the FNO project at the Harvard School of Public Health and is based in Addis. He is an adjunct professor of health policy and systems at the University of Technology, Sydney in Australia, as well as Bahar Dar University, Walaita Sodo University, and Jimma University here in Ethiopia. Professor Merkuze had earned a Doctor of Medicine and a Master's of Public Health degree from Jimma University. Professor Merkuze, it's wonderful to have you on this panel. I think we have heard an experience from Ghana, and I was hoping that you're going to share some very practical evidences that actually informed policy and practices in improving maternal health in this country as well. Over to you. You have 15 minutes presentation.
Thank you so much, Dr. Solomon, for your generous introduction. So, in a way, I will do my presentation to complement what has been said by the previous speakers. While the previous speakers have been talking about specific evidence generated and how it informed implementation, I would mainly focus on how we used innovative local platforms to inform evidence decision making in policy making for maternal and child health in Ethiopia. So this is sort of outline for me, and I think these are the stories you know very well. Maternal mortality in Ethiopia is among the highest. Recent figures, estimates indicate that we are doing a good job in terms of making progress towards our target. But our most recent survey, EDHS 2024-25, shows that 141 women per 100,000 live births die from maternal causes. And major causes are similar to what was mentioned by the presenter from Ghana. So postpartum hemorrhage, hypertensive disorders, sepsis, obstructive labor, unsafe abortion are the common causes, and strong regional and socioeconomic inequalities persist. So in terms of addressing these challenges, we need research. Why? Because in research, as you might understand, is clearly important in understanding what works for whom and under what circumstances. And as clearly stated by the previous speakers, context or the circumstances in which programs are implemented are of paramount importance. And we frame problems and understand the mechanisms of solving problems only within context. Otherwise, implementation would be less informed. So research would inform development of clinical guidelines, health system design and service delivery, policy and financing decisions by policymakers. And it also supports accountability and learning within a health system. So for this purpose, we need research evidence to really inform the design implementation of maternal interventions. So to broadly, talk about evidence-informed decision-making, which is a concept which has now been in place for about a decade a decade or two in public health and health system, but has been there in clinical medicine for long. So this is a process whereby we systematically identify, appraise, and mobilize the best available evidence to inform safe and effective health programs and policy designs. But as you can see from the Venn diagram, it's not enough to have a good or quality evidence to inform decision making. We have to also take into consideration the context, as we have repeatedly said in this webinar, the context about the community's health issues, the culture, the norm, and the preferences of the community, and of course the resource constraints that we have in place. And we have to blend it with expertise that we have in place. So all of these are taken into consideration in making decision. It's not only the type and quality of the evidences that we use to inform decisions. So the enabling factors within the Ethiopian health system to facilitate evidence-informed decision-making in maternal health program design and implementation include the revised national health policy, which clearly indicates the value of including evidence-informed strategies to solve health problems in general and maternal health problems in particular. And research institutions of MOH, it has got two big research institutes which are commissioned to conducting research and provide technical support to the ministry and its subnational structures. We have a national health sector development strategy, which again emphasizes the value of using research evidence to inform decision making all along the system. And different levels of the health system have come up with innovative approaches, such as establishment of knowledge translation platforms to facilitate interaction and interconnection between researchers and policymakers and program managers within the system. And a couple of years ago, the Ministry of Health also took a very bold step to establish a department under the Minister's Office, which is mandated in facilitating evidence used to inform decision making. And different universities in the country are also good at producing a lot of evidence relevant to informing decision making in maternal health program design and implementation. But there are challenges, although we have a lot on our table in terms of good evidence to inform decision making, including local and global evidence. There is a disconnect between research evidence producers and users. A lot of evidence is being generated at universities, research institutes, and big reports are being written. A lot of publications are coming out, but the users, those who are supposed to make decisions informed by the evidence from these research products, are not usually, in touch with these products for several reasons. One, they were not involved in the production. Two, the evidence is not in the appropriate format for use. And sometimes it's too complicated for them to digest it and use it for decision making. And academic incentives prioritize publication over uptake. It's rarely that academic staff in universities asked to produce evidence of research evidence uptake for informing decision making. They are asked for publications and citation and so on. So that's how it's framed, and lack of institutional capacities and resources to translate knowledge into practice and policy is also another hurdle. By this, I'm referring to, the lack of infrastructures that enable access to and use of evidence by the policymakers at different levels of the health system. And there is also misalignment of research outputs, although we have a lot of evidence out there, even of good quality and published on good journals. These are rarely aligned in terms of timelines and needs of the policymakers who are supposed to use it. And there is, as I mentioned earlier, little effort to really facilitate access to existing evidence to the policymakers, and there is lack of coordination among key actors, to really facilitate evidence co-creation, then ensuring translation of evidence to inform real-world activities. So, in response to this challenge, the maternal child adolescent health service lead executive office at the Ministry of Health came up with a local innovation whereby it bridges the gap, the gap between those who produce evidence within the country and the health system policymakers. This platform is known as the RMNSH RAC. So the Research Advisory Council, that's how it is spelled out. So in terms of history, it was established in 2015. It started as a means of bridging policymakers and researchers in reproductive health research uptake, but it later expanded to engaging in other sub-programs within the Department of Maternal and Child Health. So as we speak, we have 4 thematic groups in this Research Advisory Council, which is constituted by researchers from universities, research institutes in the country, and partner researchers from partner organizations, and of course program managers from the health system comprise the team. So these are the four sub-teams: maternal health, family planning, newborn and child health, and immunization. And these sub-teams correspond to the sub-programs managed by the department at the ministry. So these are four desks or sub-programs managed by the department, and they are served by these sub-thematic groups within the Research Advisory Council. So what does it do? It tries to identify and prioritize key research areas to inform policymaking in RMNCH, advocate for the use of evidence in RMNCH, work with TWGs, task forces established by the ministry to facilitate inculcating evidence in operational guidelines, and participate in the development of technical policies, documents, and standards. So by doing so, it really bridges the disconnect between the policymakers and the research, the research product producers. So these are some of the cases, just to give you a flavor of what happens through this Research Advisory Council. So I will focus on maternal health, and on the left side, you see management of PPH to reduce maternal mortality, which is a leading cause of maternal mortality in the country. So, for example, the first bullet refers to UBT, NASG, and TXA as a means of addressing the problem of postpartum hemorrhage among women delivering in hospitals. So this intervention was recommended by WHO long ago, and it was this evidence, this recommendation was assessed and contextualized by the Research Advisory Council before it was adopted. Community distribution of misoprostol again was recommended by WHO as part of the package to address PPH. And community distribution had a lot of concerns in its nature. It might be, people feared that it might be misused for other purposes, and it might also discourage women from seeking delivery care at facilities. So this concern was studied by the Research Advisory Council, and finally the Research Advisory Council concluded that this fear among the policymakers was not founded on evidence. So it recommended finally to introduce misoprostol, as one of the component measures to mitigate PPH. And delivery of quality oxytocin to the point of care. The quality of oxytocin that we give to women in the delivery room is really critical, because it is a means of stopping bleeding to the mother. We have to make sure that we give potent oxytocin. And as you know, oxytocin is temperature reliable and heat sensitive. People were worried about how to keep the cold chain system. So the solution proposed by the maternal health team was to use the immunization cold chain system in the country, to the point of care in the health facilities, because the delivery rooms do not have their own refrigerators. So this was not easy to do, although we might think this is an efficient way of addressing the problem. The EPI team actually opposed to this. So this is a policy dilemma, and it was handled by the Research Advisory Council, which studied experience from the different similar settings, synthesized the evidence, then conducted rounds of Delphi consultations from experts to understand the situation. And finally, as we speak, they have prepared an operational guideline to inform introduction of oxytocin within the cold chain. So to improve its quality and make sure that we give potent oxytocin to women delivering in the health facilities. So there are so many of similar circumstances where the Research Advisory Council was used to contextualize evidence, to synthesize evidence and package it in a way it is suitable for use by the research, by the policymakers in the Ministry of Health. So in conclusion, we have learned over the years while working with the Research Advisory Council, we have learned that we have a lot of evidence, as been said by the earlier speakers. There exists strong evidence on what works for majority of the maternal health problems. The challenge is how to implement at scale and with good quality. So for that, we need local innovations such as the Research Advisory Council to really facilitate the co-creation, productions and synthesis and presentation of evidence to policymakers to really facilitate use of evidence to inform implementation of maternal health. So the call to action is researchers need to work with policymakers to align their research with system needs and invest in implementation. We have to invest in implementation science and use evidence to really make sure that we reach most underserved women within our context. And by doing so, we will ensure not only quality implementation, but also address equity lens in a way. So thank you very much. That's it from me.
Thank you so much, Professor Mercouzet. I think you've also touched upon a very, very important points. You took us a little back in trying to show the importance of evidence-informed decision making. Also highlighted the problem with evidence generation by itself is not enough unless you have a user. And then you've also shared your experience of coming up with a solution, which is the Research Advisory Council, to close the gap between an evidence generation and the consumption of the evidences. That's quite an experience and worth sharing. You've also highlighted how some evidences are powerful enough in terms of shaping some practices which were very long standing. And finally, at the rest of the speakers, you've also emphasized on the importance of implementation science, because at the end of the day, evidences, unless they help us solve problems, that's not evidence. We don't need evidence just for the sake of evidence, but at the end of the day, we use evidence to solve problems. So you highlighted the importance of implementation science. Thank you so much. I think having said that, I encourage participants to put your question in the Q&A box. So far, we have about 9 questions. I'm not sure if the speakers have tried to type the answers on the text, but I just would read it to the panelists. Any of you, you can jump to respond to the questions posted here. It shouldn't have to be your own, it's not only directed, there is no specific question directed to an individual, except one for Dr. Laura, which is, it says a quick question that I heard, measuring trust. Yes, that's very critical. But how? I think the participant would like to learn. I think it's you wants to learn about, so you've said that trust is important, but at the end of the day, Laura, how are you going to measure trust? Is his question. Otherwise, for the rest of the speakers, there is a question from Fukadu that says the last remark is the implementation quality, which is a very important thing, but often less measured and reported. So what are your suggestions? Is the question. A question from Sugma is, to implement the research in big scale, like at country level, you should persuade the government. Sometimes it's an obstacle. How do you think of that? Any suggestion is the question. The other one is, I think Anna tried to respond to that, I guess. Anna, you like also maybe to try to react if you want. There is anonymous attendee who also asked the evidence generated by the academicians. What practical strategies would you recommend to harmonize and streamline the sharing of academic evidence with the implementers so both sides can truly leverage each other's efforts and accelerate real-world impact? That's Hannah also would like to respond to that, I guess. I can see that. But you could also reflect if you want. Same anonymous attendee also commented here, great overview on the process of evidence-based decision making. Do you consider visibility and acceptability of those interventions and decision making in addition to efficacy? I think this is maybe to Professor Mkuze. Joy asked, I'm just wondering whether there is any research in Ethiopia in using emotive for early detection of PPH. Merkuze, you may respond to this. Another question from anonymous attendee is, while the reported maternal mortality ratio decreased from 195 to 141 per 100,000 live births, I've observed that many maternal deaths in remote communities are not reported due to political and system challenges. For example, in 2019, 6 maternal deaths occurred in one area but were not officially reported. How can we strengthen maternal death surveillance system to ensure accurate reporting and accountability, especially in politically sensitive and resource-limited setting? Maybe this is for Murkuze and Hannah. I think because the context might be similar. I don't know how the data, reporting transparency when it comes to reporting maternal death is like in Ghana. You probably would also share that. And Murkuze, if you know anything about this, I think the participant would like to hear on as well. You also come back with another question. As you highlighted, the research products are not being optimally utilized by decision maker. It must be for Merkuze. I believe there is a critical gap between research production and its practical use by program implementers. In your view, what strategies would you recommend to strengthen capacity for evidence demand and use among policymakers and program implementers? I think I would say that this might be the last. Yeah, what else? Yes. PHC, all right. What about the role of AI in reduction of maternal health improvement? How do you address equity and access in health service? These are some of the questions posted. And the last is, are we in a position to compare EDHS 2016 and 2025? I think somebody asked about regarding the maternal mortality, looking at the first EDHS. What's your take on ESS use of data source? This is directed to Professor Merkuze. I think these are some of the questions asked. I would say maybe anybody can step in. I think Merkuze can come first, so you can go ahead react, and then Laura, Anna, you can start warming up. Then go ahead, Merkuze.
Okay, thank you. Thank you for your interest and for the questions. Maybe to begin with the easiest question. So emotive, yes, it's being piloted, being studied in some of our hospitals. The study is being led by St. Paul Medical College. So the results are not yet ready. So it's being worked on. In terms of improving data systems to capture maternal mortality, I think we know for sure, people who have exposure to the Ethiopian health system know very well that we have issue with the quality of the data that we capture from our routine data system. But I think given the move towards digitalizing data capturing, starting from the community level, I think this might improve. But we have to work hard on changing the behavior of people at the inputs level, at the facility level. As you rightly mentioned, there is a fear of, blame and so on. So that has to be reframed, I would say. It's natural for people to be afraid of if they are going to be blamed because of what they report. So that has to change. And at the same time, the platform should be digitalized as opposed to the paper system that dominates to date. So that will improve. So we have to work on infrastructure and on people's behavior. And improving capacity for evidence, for demanding evidence. So in my experience for the last 8 years, I have witnessed change in demand for evidence among policymakers in regional health bureaus and in the Ministry of Health in particular departments with which I worked. Why did that happen? Because we intentionally worked to build their capacity, provided trainings, tailor-made trainings on, understanding the policymaking process, on how to navigate, how to do communication of evidence in that environment. And we also trained researchers to really work, communicate, and negotiate, co-create evidence together with policymakers. So that intentional effort to really bridge the gap between the policymakers and the researchers have really yielded with a very good outcome, I would say. So if you go to now the Maternal and Child Health Department at the Ministry of Health, whatever decision the policymakers make, they ask for evidence. This is amazing. Some 5-6 years, it was not the case. So we can, if we intentionally work, that could really happen, I would say. So it should be intentional, and we have to work on not only on policymakers, but also on researchers to really help them work together. How far evidence is linked to decision making in Ethiopia? So that really depends on to whom you talk to and where you visit. So depending on whether the department has worked intentionally to really improve the situation, I would say there are changes in the last few years. Particularly in the last 10 years, there is a movement of, using systematic way of synthesizing evidence to inform decision making in Ethiopia. But it's not like every part of the health system. So we have a lot to do, but there are changes, and it is really promising. I would say that. So I think these are some of the questions. Yeah. Thank you.
Thank you. Thank you so much. You can come back if we have time. Go ahead, Dr. Lara, and then Anna. Trahan.
I think some of the questions that people ask is how do we test or collect data on things like trust, etc. And believe it or not, we will ask. That is, there are small scales of trust which we ask both of participants and of patient navigators, etc. And why Laura declares as if she is somebody, but all research needs to be mixed methods. You need both pieces of those in order to say, and you talk with the patient navigators, and sometimes they are right with the people who are participating, and it's very clear. And in others, they're different because the patient navigators have been taught one thing in one way, and that there's sometimes a gap between that and the participants. So the simple answer is to be certain that those questions are already a part of what you're doing, and there are plenty of measures. I think the more difficult piece is actually, it appeals to my linguist side, is English is not the language for everybody everywhere. So what you need to do is, of course, make sure that when you do the instrumentation or you do the qualitative, make sure that you have the languages of where you are doing the study. And there are so many. I mean, we've done a lot of work in India where they know Hindi, where they know English, but there are 154 different languages. So you need to be clear about what is spoken where and go from that. If that addresses the question.
All right. Thank you so much, Laura. Hannah?
Yes, so I think I see a number of questions I could address. And there's a question about the evidence we generate by academicians and how we, what practical strategies you would recommend to harmonize and streamline the sharing of academic evidence with implementers. So both sides can truly leverage each other's efforts and accelerate real-world impact. And I think that is very much linked to the question about how you persuade the government. These are interesting questions for me because I think the answers are actually in the framing of the question. We should not seek as researchers to streamline the sharing of academic information. I believe we should collaborate to build the evidence and the information. Because when people are building the evidence and the information with you, they trust you. Trust is very important. It's important for the implementers, it's important for governments. So we build together. We can agree on what we write for certain audience, but it should be based on trust and what the evidence is telling us. Again, when it comes to the politicians or whoever your audience is, you need to know your audience. You need to know what their interests are, what their power is. I'm sure Ghana, like many African countries, we love our MPs, that's the parliamentary candidates, members of parliaments, and they have an interest. They want to come back into political power. How do you tailor your or write up your policy brief that make them happy? That, okay, if health insurance is very good, and my people don't have money. So guess what? If you decide to enroll 50 or 20 people per district on the health insurance scheme, parliamentarian, they'll be very happy with you. These are some of the things. The end goal is to improve health outcomes, to get people enrolled in the NHIS. They don't have the means, others do. How do they come into support? So these are some of the things you need to think about as you engage with your different stakeholders and audience. The Minister of Health, Finance, they want to stay in office or see their party in office. So you need to go to them with a policy brief that makes them understand that if they do X, Y, Z based on the scientific evidence, it's indeed going to serve their purpose. They will get to be elected again, hopefully. So these are some of the things that I think you need to, think through and play around with once you are into research and all that. There was another question concerning maternal death audits and how we could, do them for them to be transparent and to work well. And I think, again, leadership is very important. Setting the tone for a maternal death audit is very important. What are the goals? If you do not create an atmosphere that says that we are here to learn from our mistakes and to improve because of what we learned from our mistakes. If you create an atmosphere of fear, then people will hide the truth. And the other thing with maternal death audits is that you also need to make sure that you have an end-to-end in stakeholder involvement. So as an example, I'm sure a lot of maternal deaths may occur in our referral institutions. However, the delays started from the periphery. Feedback needs to go back to these people. Trainings need to go back to these people. So it's not just maternal death audit in isolation, but you need to have a certain mechanism, a certain process that it's tied from one end of the system to the other end of the system. I did see another question about, do you consider feasibility, acceptability of these interventions in your decision making? And I think the answer is a big, 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 big yes. And there are many tools to help us measure feasibility, like the systems usability skills. They are available. You can always tweak them to suit your context. But there is no point in having an intervention that is not fit for purpose. It doesn't fit your context. It will not work. Let me scroll and see. I think there was an interesting one I thought I'll respond to because I do vaccine trials. So one says, how can one increase vaccine I guess it should be decreased vaccine hesitancy, especially for newly coming vaccines and pandemics. Again, it's your community engagement. It's about being transparent. It's about building trust. These are very key elements. When we do design the trials, we spend a lot of money on the hardcore outcomes, bringing in the logistics, the administrative work, but we need to make a lot of efforts to engage our communities, because when our communities trust us, they know us, they trust us. Have them visit your facility to see what is going on over there. Have them visit your sites in the communities to understand, listen to them. These are crucial to improve vaccine acceptance in our countries. I think for now, I will stop here. If I see any more, I will jump in again. Thank you.
Thank you so much, Anna. Thank you, Laura. I think quickly, I just also want to build on what you said, Anna. When it comes to communicating with policymakers and politicians, I think the problem with most of us as public health professionals, and of course clinician, is that we fail to come up with the right language in terms of communicating with these people. We just bring them the raw data, which makes no sense to them. So, making it appealing in the way they understand it and in the way that resonates to them is the right way. It's quite also a communication at all level to everyone is quite an important competence of a public health professional. So this is also something that as public health professionals that we need to work on ourselves. How do you talk to the policymakers? What is the language that we should use? How do we present data? What kind of data? In what form is quite something that we need to work on ourselves. But I believe that we're all deficient in this area. The problem is not with them if they fail to act on. The problem is with us. It's because that we fail to make it appealing and it makes sense in the way they understand it, that they fail to act it. Otherwise, as you mentioned, you can hold them in a way that actually is a threat to their position is one, but also, some are out of goodwill as well, if they understand. That's also one important thing that you've mentioned. Maybe I'm also happy that you've reacted to why people hide some maternal leases. I think it's everywhere. It's because of accountability, and also people miss the whole purpose of doing the maternal leave audit. This is to learn, this is to improve. If people fail to understand the importance, the significance, and the purpose behind doing it, they keep on lying it. And I would say this is entirely a leadership gap. This all failure comes because of leadership. The leadership should be able to build a trust for people that why they do it, what they do it. And if they understand it, the people should for sure would be honest. And then I think they won't hide those data, those critical data. And that's quickly, I just want to build on that. So we have also 5 more minutes if you like to step in and also want to respond to that. Maybe one is from Sister Razib to Professor Merkuze in terms of, how do you bridge the gap between the evidence and implementation? Maybe if you could respond to that. But before that, Laura, would you like to say anything? Would you like to respond to that? Do you have anything that you would like to say? If there is any specific question for Adato, or you can also comment that if you feel that it is something has to be said, just go ahead. Like, it shouldn't have to be a question. And then Merkuze. So we're 5 minutes to close. Go ahead, Laura.
I think that the bottom line is these are all, I assume, students and would-be researchers or researchers in and of themselves, is to become educated. That is, you're already doing this, but in terms of particular methods, because unfortunately, many times the people say, well, yeah, the statistician will take care of this, or the PI is the one who's about these sorts of things. It really needs to be a shared responsibility among everybody on the team and among everyone that you communicate with or work with in developing this sort of thing, so that everyone is clear. It's not just this job or this job, that we need to plan holistically in terms of, for example, the questions of trust we're talking about, or the type of design that we need to use. And the only thing I'd say about politicians is you just have to show them how this is going to benefit them and perhaps reelect them. And that's okay with me if they have great cooperation with us into doing the work that we can do. And no doubt there are also politicians who actually care about the research. So if you can move these two together, I think you're at a better chance of being successful.
Yeah. Thank you so much. Thank
Yeah,
you,
yeah.
Dr.
Thank you. So I think I have in fact reflected on what Sister Azeb asked earlier. So the link really varies for depending on which level you are talking about, which department of the health system, and so on. So I would like to, complement what Dr. Salaman, yourself, and Laura just said. This tendency of blaming each other would not take us anywhere. So it is our responsibility, researchers and the policymakers, to really work together. So one of the participants asked, what is the best way of, like ensuring the uptake of my research evidence by policymakers? It is to work with them. So starting day one, from the design of your research, talk to the policymakers. Are you in the first place trying to research or investigate something that is which is of interest for them? So make sure that you research something of interest, then continue engaging them until the end of the research project. That way, they will not even wait for publication of your results. They will immediately take it up, inform their planning, inform their revision of guidelines, inform their policy crafting using your evidence. So it is about making it relevant to them, aligned to their timelines, and aligned to their needs. So that would really maximize uptake of evidence. One more question, probably two more questions for me by Kurabacho. An interesting question. It is about, making it contextual, relevant, and so on. So how do policymakers check that? They should be systematic. One of the things we train them on when we do capacity building for policymakers and health managers is we clearly show them that the fact that an evidence is published on the Lancet does not guarantee its quality. So make sure that you do your own assessment, your own, check of quality, contextual relevance, and so on. Then decide whether you have to apply it or not. So it's not only that the quality is good as claimed by the researchers, the policymakers themselves have to really check that before they do. I think time is up for the last question,
Yes.
so thank you.
Yeah. Thank you so much, Professor Merkuzi. I think we should stop here for interest of time, and I hope we can go on talk the whole day. The issue is quite hot, and I believe that the organizers are going to come up with something similar to this, so that people would, satisfy their, with the satiety for knowledge, and I believe on that. So this is not going to be the last. But from me, I just want to thank the panelists and the speakers for their wonderful talk, their insights, and for making time to show up here and share their experiences on the subject. Thank you so much, Professor Merkuze. Thank you so much, Dr. Laura. Thank you so much, Dr. Hannah. Have a wonderful time. It's over from my side. Maybe if they have any housekeeping issue from Tirsit and Dr. Takwam, I will give the floor to them. But participants are asking if it's okay that you share your presentations, panelists. If you say okay, we'll be sharing with the participants for their references. Great. Thank you so much. So, Tirsit, Takwam, should I close it? Should I say goodbye to the participants or any housekeeping issue? All right, once, twice.
Nothing from me, Solomon. Thank you so much.
Yeah.
Wonderful session. You may go ahead and close the session. Thanks everybody for joining.
All right, thank you, participants. All right, over. Hope to see you soon. Bye-bye.
Excellent. Thank you.
Thank you.